Welcome to this comprehensive lecture on pediatric mitral regurgitation. I'm Dr. Abdelaziz Yousef, and today we'll explore this important cardiac condition through a case-based approach. This presentation is designed specifically for practicing pediatricians, covering everything from basic anatomy to management strategies. Throughout this lecture, we'll follow a structured format with clinical questions followed by detailed explanations to enhance your understanding of mitral regurgitation in children. This content is brought to you by Pediatric Case Review. Question number 1 focuses on the anatomy and physiology of the mitral valve. The question asks which of the following is not a component of the normal mitral valve apparatus. The options are A. Annulus, B. Leaflets, C. Papillary muscles, and D. Semilunar cusps. Take a moment to consider your answer before we proceed to the explanation. This question tests your fundamental knowledge of cardiac anatomy, which is essential for understanding mitral regurgitation in pediatric patients. The correct answer is D. Semilunar cusps. The mitral valve apparatus consists of 4 main components: the annulus, which is the fibrous ring that supports the valve leaflets, the leaflets themselves, including the larger anterior and smaller posterior cusps, the chordae tendineae, which are tendinous cords connecting the leaflets to the papillary muscles, and the papillary muscles, which anchor the chordae and prevent leaflet prolapse. Semilunar cusps are actually components of the aortic and pulmonary valves, not the mitral valve. Understanding this anatomy is fundamental to recognizing how mitral regurgitation develops when any of these components are damaged or dysfunctional. Question number 2 addresses the etiology of mitral regurgitation in pediatric patients. The clinical scenario describes a 10-year-old child who has developed new-onset mitral regurgitation after experiencing recurrent episodes of pharyngitis. The question asked for the most likely etiology from the following options: A. Congenital mitral valve anomaly, B. Rheumatic heart disease, C. Marfan syndrome, or D. Mitral valve prolapse. Consider the relationship between recurrent pharyngitis and potential cardiac complications as you determine the most likely cause in this case. The correct answer is B. Rheumatic heart disease. The clinical scenario strongly suggests this diagnosis because of the clear temporal relationship between recurrent pharyngitis and the development of mitral regurgitation. Group A streptococcal pharyngitis can trigger rheumatic fever through an autoimmune response, which can then lead to carditis and subsequent valve damage. The mitral valve is the most commonly affected valve in rheumatic heart disease. Congenital mitral valve anomalies typically present earlier in life and are not associated with pharyngitis. Marfan syndrome would have other characteristic physical features not mentioned in the case. Mitral valve prolapse is usually idiopathic or familial, not triggered by streptococcal infections. Rheumatic fever remains a significant cause of acquired heart disease in children, especially in developing countries with limited access to healthcare. This table provides a comprehensive classification of the various causes of mitral regurgitation in pediatric patients. Congenital causes include structural abnormalities present at birth, such as atrioventricular septal defects, cleft mitral valve prolapse, and parachute mitral valve. Acquired causes develop after birth and include rheumatic fever, which remains a significant global health issue, infective endocarditis, cardiomyopathy, and Kawasaki disease. Several genetic syndromes are associated with mitral valve dysfunction, including Marfan syndrome, Ehlers-Danlos syndrome, Williams syndrome, and Hurler syndrome. Additionally, mitral regurgitation can occur as a complication following surgical repair of other congenital heart defects like ventricular or atrial septal defects. Understanding these various etiologies is crucial for appropriate diagnosis, management, and prognostication in pediatric patients with mitral regurgitation. Question number 3 explores the pathophysiology of mitral regurgitation. The clinical case describes a 12-year-old child with chronic mitral regurgitation who presents with cardiac enlargement. The question asks which cardiac chamber would likely demonstrate the earliest and most significant dilation. The options are A. Right atrium, B. Right ventricle, C. Left atrium, or D. Left ventricle. Consider the hemodynamic consequences of mitral regurgitation and the sequence of changes that occur in the cardiac chambers as the condition progresses. Understanding this pathophysiology is essential for recognizing the clinical manifestations and determining appropriate management strategies. The correct answer is C. Left atrium. In chronic mitral regurgitation, the left atrium experiences the earliest and most significant dilation because it directly receives the regurgitant blood flow from the left ventricle during systole. The left atrium must handle both the normal pulmonary venous return and the additional regurgitant volume, creating a volume overload state. The left atrium also has greater compliance than the left ventricle, allowing it to dilate earlier in response to this increased volume. The pathophysiologic sequence typically progresses as follows. First, left atrial dilation occurs due to the regurgitant flow. Second, the left ventricle experiences volume overload as it must pump both the normal forward stroke volume and the regurgitant volume. Third, left ventricular dilation develops as a compensatory mechanism. And finally, reduced forward cardiac output occurs as the ventricle becomes less efficient. Question number 4 focuses on the clinical presentation of mitral regurgitation. The clinical scenario describes an 8-year-old child presenting with fatigue, dyspnea, and palpitations. The question asks which physical examination finding would be most consistent with significant mitral regurgitation. The options are A. Ejection systolic murmur at left upper sternal border. B. Pansystolic murmur at apex radiating to axilla. C. Mid-diastolic rumble at apex. Or D. Continuous machinery murmur. Consider the characteristic auscultatory findings of mitral regurgitation and how they differ from murmurs associated with other cardiac conditions. Recognizing these specific physical examination findings is crucial for the clinical diagnosis of mitral regurgitation in pediatric patients. The correct answer is B. Pansystolic murmur at apex radiating to axilla. This is the classic auscultatory finding in patients with significant mitral regurgitation. The murmur is pansystolic or holosystolic, meaning it occurs throughout systole. It is best heard at the cardiac apex, which corresponds to the fifth intercostal space in the left midclavicular line. A characteristic feature is its radiation to the left axilla, which helps differentiate it from other systolic murmurs. The intensity of the murmur typically correlates with the severity of regurgitation, though this relationship is not absolute. The murmur is increased by maneuvers that enhance left ventricular volume or reduce afterload, such as assuming the left lateral decubitus position or during expiration. In contrast, option A describes an ejection systolic murmur, which is typical of aortic or pulmonary stenosis. Option C describes a mid-diastolic rumble, characteristic of mitral stenosis. Option D describes a continuous machinery murmur, which is pathognomonic for patent ductus arteriosus. Recognizing these distinctive auscultatory features is essential for the clinical diagnosis of mitral regurgitation in pediatric patients. This table provides a comprehensive approach to the physical examination of pediatric patients with suspected mitral regurgitation. When assessing special facies, clinicians should look for features suggestive of underlying syndromes associated with mitral valve disease, such as the characteristic appearance of rheumatic heart disease, the tall stature and arachnodactyly of Marfan syndrome, or the hyperelastic skin seen in Ehlers-Danlos syndrome. Importantly, clubbing and cyanosis are not typically associated with isolated mitral regurgitation. Pulse and neck examination are usually normal in pure mitral regurgitation, but clinicians should evaluate for signs of associated conditions like aortic regurgitation or infective endocarditis. Inspection may reveal surgical scars in patients with previous cardiac interventions, which could indicate residual mitral regurgitation following repair of other conditions like atrioventricular septal defects or ventricular septal defects. Question number 5 addresses the diagnostic approach to mitral regurgitation in pediatric patients. The clinical scenario describes a 9-year-old child with suspected mitral regurgitation who requires diagnostic confirmation. The question asks which diagnostic modality would be most appropriate as the initial test. The options are A. Cardiac MRI, B. Cardiac catheterization, C. Chest X-ray, or D. Echocardiography. Consider the advantages, limitations, and appropriateness of each diagnostic modality for the initial evaluation of suspected mitral regurgitation in children. Factors to consider include diagnostic accuracy, availability, invasiveness, radiation exposure, cost, and the ability to provide comprehensive anatomic and functional information about the mitral valve and cardiac chambers. The correct answer is D. Echocardiography. This imaging modality is considered the gold standard for the initial diagnosis and assessment of mitral regurgitation in pediatric patients. Echocardiography offers numerous advantages that make it ideal for this purpose. It is non-invasive, does not involve radiation exposure, is widely available, and provides comprehensive real-time evaluation of cardiac structure and function. With echocardiography, clinicians can determine the etiology of mitral regurgitation by identifying specific structural abnormalities, quantify the severity of regurgitation using parameters such as regurgitant fraction and effective regurgitant orifice area, assess chamber dimensions, including left atrial and left ventricular size, and evaluate ventricular function. Color Doppler echocardiography allows for direct visualization of the regurgitant jet, providing immediate confirmation of the diagnosis. While cardiac MRI offers excellent anatomical detail, it typically requires sedation in young children, is less accessible, and more expensive. Cardiac catheterization is an invasive procedure with associated risks and is generally reserved for complex cases or when intervention is planned. Chest X-ray may show cardiomegaly and significant mitral regurgitation, but cannot directly diagnose the condition or assess its severity. For these reasons, echocardiography remains the most appropriate initial diagnostic test for suspected mitral regurgitation in children. This table summarizes the complete diagnostic approach for pediatric patients with suspected or confirmed mitral regurgitation. Echocardiography serves as the definitive diagnostic test, providing comprehensive assessment of the mitral valve structure, function, and severity of regurgitation. It allows for direct visualization of the regurgitant jet using color Doppler and provides quantitative measurements such as regurgitant fraction and effective regurgitant orifice area. Chest X-ray findings in significant mitral regurgitation typically include cardiomegaly, left atrial enlargement, and pulmonary plethora due to pulmonary venous hypertension, though these findings are supportive rather than diagnostic. Electrocardiogram may demonstrate left ventricular hypertrophy, left atrial enlargement, manifesting as P-mitral, and occasionally atrial fibrillation in chronic cases, though these changes are not specific. Question number 6 focuses on the severity assessment of mitral regurgitation. The clinical case presents a child with mitral regurgitation and specific echocardiographic findings, a regurgitant fraction of 20%, an effective regurgitant orifice area of 0.2 square centimeters, and normal left ventricular size. The question asks how the severity of this condition should be classified, with the options being A. Trace, B. Mild, C. Moderate, or D. Severe. To answer this question correctly, you need to be familiar with the standard classification criteria for mitral regurgitation severity based on quantitative echocardiographic parameters. Consider how the provided values for regurgitant fraction and effective regurgitant orifice area correlate with the established severity categories, and how the presence of normal left ventricular size might influence the overall assessment. The correct answer is B. Mild. The classification of mitral regurgitation severity is based on established quantitative echocardiographic parameters. In this case, the regurgitant fraction of 20% falls within the mild category, which is defined as less than 30%. The effective regurgitant orifice area of 0.2 square centimeters is at the upper limit of the mild range, which is less than 0.2 square centimeters. The presence of normal left ventricular size is also consistent with mild mitral regurgitation, as significant chamber dilation typically occurs with more severe degrees of regurgitation. For moderate mitral regurgitation, the regurgitant fraction would be between 30 to 49%, and the effective regurgitant orifice area would range from 0.2 to 0.39 square centimeters. Question number 7 addresses the medical management of mitral regurgitation in pediatric patients. The clinical case describes an 11-year-old child with moderate mitral regurgitation due to rheumatic heart disease who is experiencing only mild symptoms. The question asks for the most appropriate initial management approach, with the options being A. Immediate surgical valve repair, B. Antibiotic prophylaxis and afterload reduction, C. Balloon valvuloplasty, or D. Heart transplantation. To determine the correct answer, consider the standard management guidelines for moderate mitral regurgitation in children, particularly in the context of rheumatic heart disease. Factors to consider include the severity of symptoms, the underlying etiology, the potential for disease progression, and the risks and benefits of various treatment modalities. Also consider the appropriate timing for intervention versus initial medical management in this clinical scenario. The correct answer is B. Antibiotic prophylaxis and afterload reduction. For an 11-year-old with moderate mitral regurgitation due to rheumatic heart disease and only mild symptoms, the most appropriate initial management approach is medical therapy rather than invasive intervention. Antibiotic prophylaxis is critical in rheumatic heart disease to prevent recurrence of rheumatic fever and further valve damage. Afterload reduction with medications such as ACE inhibitors helps reduce the regurgitant volume by decreasing the resistance against which the left ventricle must pump, thereby reducing the amount of blood that flows back into the left atrium. Diuretics may be added if there is evidence of volume overload, and beta blockers might be considered in selected cases with tachycardia. This table outlines the antibiotic prophylaxis guidelines for patients with rheumatic fever, which is crucial for preventing recurrence and further cardiac damage. The preferred regimen is benzathine penicillin G administered intramuscularly every 3 to 4 weeks, as it provides the most reliable protection against streptococcal infections. For patients with rheumatic fever without carditis, prophylaxis should continue for 5 years or until age 21, whichever is longer. In cases where carditis is present but there is no residual valve disease, the duration extends to 10 years or until age 21, whichever is longer. The most intensive prophylaxis is required for patients with carditis and residual valve disease, where prophylaxis should continue for 10 years or until age 40, whichever is longer, with consideration given to lifelong prophylaxis in severe cases. Question number 8 focuses on the surgical indications for mitral regurgitation in pediatric patients. The clinical case describes a 7-year-old child with severe mitral regurgitation who has New York Heart Association Class II symptoms, a left ventricular ejection fraction of 60%, and evidence of progressive left ventricular dilation. The question asks for the most appropriate management approach, with the options being A. Continue medical therapy only, B. Refer for surgical intervention, C. Perform balloon valvuloplasty, or D. Reassess in 6 months. To determine the correct answer, consider the established criteria for surgical intervention in pediatric patients with severe mitral regurgitation. Factors to evaluate include the severity of regurgitation, the presence and severity of symptoms, ventricular function, evidence of ventricular dilation, and the potential for irreversible myocardial damage if intervention is delayed. The correct answer is B. Refer for surgical intervention. This 7-year-old patient with severe mitral regurgitation meets multiple criteria for surgical intervention. The presence of New York Heart Association Class II symptoms indicates mild limitation of physical activity due to cardiac symptoms, which is an indication for surgery in severe mitral regurgitation. More importantly, the progressive left ventricular dilation is a key surgical indication, as it signifies ongoing volume overload that can lead to irreversible myocardial damage if not addressed. Although the left ventricular ejection fraction of 60% is still within the normal range, the progressive dilation suggests that ventricular function is at risk and intervention is warranted before significant dysfunction develops. This table provides a comprehensive overview of the surgical approaches for mitral regurgitation in pediatric patients. Valve repair techniques are preferred when feasible and include annuloplasty with ring or band implantation to reduce the annular size, leaflet repair involving resection, plication, or closure of clefts, portal procedures such as transfer, shortening, or replacement of chordae tendineae, and commissuroplasty for reconstruction of the commissures. Valve repair is particularly advantageous in children as it preserves the native valve tissue and allows for growth. Valve replacement options include mechanical valves, which are durable but require lifelong anticoagulation, and bioprosthetic valves, which have limited durability in children due to accelerated degeneration. Homografts are rarely used in the mitral position, and the Ross procedure is not applicable for mitral valve disease. Question number 9 focuses on the management of prosthetic heart valves in pediatric patients. The clinical case describes a 13-year-old who has undergone mechanical mitral valve replacement. The question asks which of the listed options is not required in their follow-up care. The options are A. Warfarin anticoagulation, B. Regular INR monitoring, C. Antibiotic prophylaxis for dental procedures, or D. Annual cardiac catheterization. To answer this question correctly, you need to be familiar with the standard follow-up care requirements for pediatric patients with mechanical prosthetic heart valves. Consider the necessary components of long-term management, including anticoagulation therapy, monitoring requirements, infection prevention strategies, and appropriate surveillance methods. Identify which of these options is not typically part of the routine follow-up care for patients with mechanical prosthetic valves. The correct answer is D. Annual cardiac catheterization. While warfarin anticoagulation, regular INR monitoring, and antibiotic prophylaxis for dental procedures are all essential components of follow-up care for patients with mechanical prosthetic heart valves, annual cardiac catheterization is not routinely required. Patients with mechanical prosthetic valves require lifelong anticoagulation therapy with warfarin to prevent thrombus formation on the valve. Regular monitoring of the International Normalized Ratio, INR, is necessary to maintain therapeutic anticoagulation, with a target range typically between 2.5 to 3.5 for mitral valve prostheses. Antibiotic prophylaxis is recommended for dental procedures and other interventions that may cause bacteremia to prevent prosthetic valve endocarditis. Echocardiographic follow-up is performed regularly to assess valve function and detect any complications. However, Annual cardiac catheterization is not part of routine surveillance due to its invasive nature, associated risks, radiation exposure, particularly concerning in children, and the availability of non-invasive alternatives like echocardiography that provide adequate assessment of valve function. Cardiac catheterization is reserved for specific indications such as suspected valve dysfunction, unexplained symptoms, or preoperative planning when intervention is being considered. Pediatric patients with prosthetic valves face additional challenges, including anticoagulation management with activity restrictions, growth considerations that may necessitate future reoperations, psychosocial impacts related to body image and activity limitations, and the need for structured transition programs to adult care. Question number 10 addresses mitral regurgitation in special populations, specifically focusing on Marfan syndrome. The clinical case describes a 6-year-old child with Marfan syndrome who has mild mitral regurgitation. The question asks which finding would be of most concern for rapid progression of the mitral regurgitation. The options are A. Mild aortic root dilation, B. Severe myopia, C. Moderate mitral valve prolapse, or D. Joint hypermobility. To answer this question correctly, you need to understand the cardiovascular manifestations of Marfan syndrome and their natural history. Consider which of these findings is most directly related to the progression of mitral valve dysfunction in patients with Marfan syndrome. Also consider the underlying pathophysiology of mitral valve disease in this connective tissue disorder and how different clinical features might influence the rate of progression. The correct answer is C, moderate mitral valve prolapse. In patients with Marfan syndrome, moderate mitral valve prolapse is the finding of most concern for rapid progression of mitral regurgitation. Marfan syndrome is a connective tissue disorder caused by mutations in the FBN1 gene, which encodes fibrillin 1. This genetic abnormality leads to progressive myxomatous degeneration of the mitral valve tissue, resulting in thickened, redundant leaflets that are prone to prolapse. The presence of moderate mitral valve prolapse indicates significant structural valve abnormality that is likely to worsen over time due to ongoing connective tissue abnormalities. As the prolapse progresses, chordal elongation and annular dilation further exacerbate the regurgitation. In contrast, while mild aortic root dilation is an important feature of Marfan syndrome that requires monitoring due to the risk of aortic dissection, it is not directly related to the progression of mitral regurgitation. Question number 11 focuses on mitral regurgitation in neonates. The clinical case describes a 2-week-old infant presenting with respiratory distress and poor feeding. Echocardiography reveals mitral regurgitation with a cleft anterior leaflet. The question asks which condition this finding is most likely associated with the options being A. Rheumatic heart disease, B. Atrioventricular septal defect, C. Coarctation of aorta, or D. Tetralogy of Fallot. To answer this question correctly, you need to understand congenital mitral valve anomalies and their associated conditions. Consider the significance of a cleft anterior mitral leaflet in a neonate in which congenital heart defects are commonly associated with this specific anatomical finding. Also consider the age of presentation and how this might help differentiate between various etiologies of mitral regurgitation in infants. The correct answer is B, atrioventricular septal defect. A cleft anterior mitral leaflet is a hallmark anatomical feature commonly associated with atrioventricular septal defects, AVSD. This association has an embryological basis, as both structures develop from the common atrioventricular valve tissue during cardiac development. In AVSD, there is a deficiency of the atrioventricular septum, resulting in a common atrioventricular valve that may be partitioned into mitral and tricuspid components, often with a cleft in the anterior mitral leaflet. This cleft can lead to mitral regurgitation, which is often significant and presents early in life. The clinical presentation described in the case, respiratory distress and poor feeding in a 2-week-old, is consistent with early heart failure due to significant mitral regurgitation associated with AVSD. Rheumatic heart disease is an acquired condition that cannot be present in neonates, as it requires previous streptococcal infection and the subsequent development of rheumatic fever. Coarctation of the aorta is a left-sided obstructive lesion that is not associated with cleft mitral valve. Tetralogy of Fallot is a cyanotic congenital heart disease characterized by pulmonary stenosis, ventricular septal defect, overriding aorta, and right ventricular hypertrophy, with no association with mitral valve cleft. AVSD has a higher prevalence in children with Down syndrome, and the cleft mitral valve associated with this condition typically requires surgical repair, often in the first year of life, with cleft closure as part of the corrective procedure. Question number 12 addresses the prognosis of mitral valve repair in pediatric patients. The question asks which factor is associated with the best long-term prognosis after mitral valve repair in children. The options are A. Repair performed after development of symptoms. B. Preoperative left ventricular ejection fraction less than 50%. C. Repair performed before significant left ventricular dilation. Or D. Rheumatic etiology. To answer this question correctly, you need to understand the prognostic factors that influence outcomes following mitral valve repair in pediatric patients. Consider how the timing of intervention, preoperative ventricular function, and underlying etiology might affect long-term outcomes. Also consider the pathophysiological principles that explain why certain factors might be associated with better or worse prognosis after surgical repair of the mitral valve in children. The correct answer is C. Repair performed before significant left ventricular dilation. Early intervention before significant ventricular dilation occurs is associated with the best long-term prognosis after mitral valve repair in children. This is because chronic volume overload from mitral regurgitation leads to progressive left ventricular remodeling, including dilation and changes in myocardial architecture that can become irreversible if allowed to persist for an extended period. When repair is performed before significant dilation occurs, the ventricle has a greater capacity for functional recovery and is less likely to experience long-term dysfunction. In contrast, repair performed after the development of symptoms, option A, is associated with poorer outcomes because symptoms typically indicate more advanced disease with established ventricular remodeling. This table provides a comprehensive structured approach to the long-term follow-up and management of pediatric patients with mitral regurgitation. Echocardiographic follow-up frequency is determined by the severity of mitral regurgitation. Patients with trace or mild regurgitation should undergo echocardiography every 1 to 2 years. Those with moderate regurgitation should be monitored every 6 to 12 months. Patients with severe regurgitation require more frequent assessment every 3 to 6 months. And those who have undergone surgical repair should be evaluated at 1, 3, 6, and 12 months postoperatively, followed by annual examinations. Thank you for joining me today for this comprehensive lecture on pediatric mitral regurgitation. We have covered the essential aspects of this condition, from basic anatomy and physiology through etiology, pathophysiology, clinical presentation, diagnostic approaches, medical and surgical management, and long-term prognosis. The key management principles include early detection through comprehensive clinical evaluation, accurate severity assessment using echocardiography as the gold standard, appropriate timing of intervention before significant ventricular remodeling occurs, and structured long-term follow-up tailored to the severity of regurgitation and individual patient factors. Remember that mitral regurgitation in children requires a tailored approach based on etiology, severity, and individual patient characteristics. Early intervention before significant ventricular remodeling leads to the best long-term outcomes. I encourage you to subscribe to Pediatric Case Review for more informative presentations on pediatric conditions, and please feel free to comment with your questions or suggestions for future lecture topics. Thank you for your attention and commitment to improving the care of children with cardiac conditions.